Good morning, good afternoon, and good evening for those of you around the world and joining us on this webinar. My name is Parag Kachalya. I'm the Vice Chair of Simulation, Technology, and Research at the University of the Pacific's Arthur A. Dagoni School of Dentistry. And we're just finishing up a day at the institution here today. I want to take a moment to thank you for sharing some of your day with me today. I'm truly humbled that so many people have taken the time on their busy schedules to listen to this webinar today and gain a little insight into how dentistry has changed. We're in a profession that is drastically transitioning from one that's focused on a surgical-based approach to where there's limitations of materials to one that's focusing on a diagnostic-based approach because equipment and technology has changed so drastically. Today, with technology and new materials, the profession has the ability to embrace these technologies and deliver conservative therapies and materials that are at the point of actually regenerating dental tissues. In the hour that we have together today, there are a few key areas that I'd like to cover. The first thing I'd like to do is present some strategies of diagnosing carious lesions, as well as erosive lesions, and then discussing some strategies on chemical intervention. I would like to discuss a few caries detection technologies that do not replace our brain, but rather provide us with an objective second opinion in terms of caries identification. We will then discuss some minimally invasive preparation strategies, and then finally, we'll finish up looking at new restorative materials that pair nicely with conservative preparations. If we take a look at this image on the left, that's one that we're used to seeing. We're used to seeing caries, and this is something that we see in our practices each and every day. And as clinicians, we need to really sit back and come to terms with the fact that caries is a disease. And it's a disease process that we deal with daily. And while we deal with caries disease and periodontal disease, these are not the only diseases that we come in contact with. We're seeing significant loss of tooth structure, and I would term erosion as a disease component as well. We're seeing significant tooth loss in so many people today due to erosion. In fact, there are teenagers walking into our offices that have never had a traditional cavity in their life, yet their dentition is significantly deteriorating because of enamel and dentin wear due to extrinsic and intrinsic acids. So caries is really not the only disease we should be concerned with, but much more. It's definitely one of the primaries, but there's other things that are taking away tooth structure. Before we head down the road of discussing dental erosion, we need to understand that caries is by no means cured. Unfortunately, caries as a disease is very much alive, and we need to think of caries differently. In order to implement a caries risk assessment protocol, we must first understand that caries is in fact a disease process. Our mindset must extend beyond simply filling teeth. Rather, we must manage the disease. We know for a fact that caries is the most prevalent disease impacting the children in the United States and other developing nations. Much of this is due to the prevalence of refined carbohydrates in the diets of our children. When we look at the current trends with respect to caries, we see that 42% of school-aged children had caries in their primary teeth. 21% of 6 to 11-year-olds had caries in their permanent teeth. Another 59% of the 12 to 19-year-olds experienced dental caries. And 92% of all individuals by adulthood will experience dental caries. These are staggering numbers when we think about the advancements in the world around us. When we think about the technologies and medications and other things that are available today, it's truly phenomenal that caries is still such a prevalent disease. Good news is there's things we can do to help fight it. Let's discuss this a bit further. Well, historically, caries was treated surgically. And other than some patient education, there's really little that was done in terms of moving people forward. So we educated patients as far as brushing their teeth, some personal hygiene aspects, but really to solve the caries process, it was more of a surgical-based approach to take the disease out, but not a whole lot was done from a prevention standpoint. Most patients were treated exactly the same when they had caries, and they weren't really managed in terms of risk assessment. Today, we must do more than surgically remove caries. As oral healthcare practitioners, we must look at a patient's risk factors and educate our patients to pair preventive therapies with surgical management. We can do this by assessing the risk for disease and pairing appropriate therapies. In my private practice, I use the American Dental Association's Caries Risk Assessment Form. I believe it's very simple to use, and my hygienist or I can complete this assessment in a matter of a couple minutes. There are many other forms out there that are available, but quite frankly, I feel safe using a form that the ADA has created and endorses. I feel there's no reason for me to reinvent the wheel. The form is free for all members. It's available on the website. And this form takes into account contributing conditions, health conditions, and clinical conditions. After taking these factors into account, we can simply make an assessment in terms of the caries process. When we think of caries, visual detection is one of the first things we do. Later in the presentation, I'll discuss advancements that have been made in caries diagnostics equipment. However, right now I just want to take a look at a few of the basic principles in diagnosing, and one is visual. If we take a look at the screen, there's two aspects. I'll show you image number 2 here, that's circled, and image number 3. The ICDOS, or International Caries Detection and Assessment System, was created to help structure a visual assessment process that looks for a few key indicators. I feel the vast majority of us can agree that a score of 0 and 1 really represent over a healthy stage, and a score of 4 through 6 represent an area in which we should intervene. I think we can all come to terms with that around the world, that 4 through 6 is probably surgical intervention involved, and 0 and 1 we're probably taking a really a monitoring approach. Stages 2 and 3, on the other hand, these are areas of debate. These are areas of debate that we see in our practices every day. We might need to focus some more accurate attention here and really think about how we diagnose those caries lesions. My goal today is not to tell you when to surgically treat caries. Rather, the goal is to actively manage any caries lesion that is evident. If we choose to not surgically treat an area, I would argue that we should still chemically manage the disease process versus watching. When we watch something, we simply watch it get worse. In my opinion, I would like to eradicate the word watch from the dental vernacular. The mouth is either in perfect oral health or it's not. If it's not, we have to ask ourselves if there's something that can be done to make it better. Watching does not make anything better. If we take a look at this image, this is what we could term as an ICDOS-2 score. What that means is this is where people are generally most unsure on ICDOS-2s. The question becomes, that dark area that you see on the occlusal surface, is a caries process beginning or not? According to the ICDOS system, if we take a look at this tooth under a wet environment and see a visual enamel change, that receives a score of a 2. A score of 2 traditionally means that about 50% of the lesion is within enamel, and the other 50% of lesion is into the outer 1/3 of dentin. Okay, and this is a system that's used in many dental schools around the country in the United States. We do this 0 through 6 scoring scale. When we see a tooth with a widening of the fissures, as seen here, is the white widening of the fissures, and discontinuity of the enamel surface, this will receive an ICDOS score of 3. In lesions like this, 77% of the lesion is histologically into dentin. More often than not, we tend to traditionally surgically treat these lesions when we see them. Now, the scoring system, it is somewhat objective. There is a process that goes into place that says we should evaluate things both wet and dry and compare and contrast. However, each person may view things slightly differently. Over the last few years, we've seen numerous caries detection devices hit the market. Over the last 20 years, this has really occurred. For many of you, you may have started with something like the Diagnodent system on the left-hand side of your screen. And this system, in the literature, shows very mixed results. About 50% of literature shows that it works pretty well, and about 50% shows that it has false positives. And it's highly dependent upon proper calibration. But the concept of caries detection was great, saying, is there an objective way through fluorescence technology or other media to detect caries versus just relying upon our own visual or tactile assessment? And I think it's very important to understand that none of these systems give us an absolute diagnosis. Rather, they all give us a new visual perspective, and you, the clinician, must ultimately decide what should be done. One of the newer devices in the U.S. marketplace is a CariView by DEXIS. It essentially mixes high-intensity light with a camera. This device works very well in identifying proximal caries that could traditionally only be seen with radiographs. In the example I'm showing you here, you can see a dark semicircle in the right-hand portion of the screen underneath the mesoproximal ridge. And this dark semicircle is essentially a breakdown. Many times in our traditional radiograph, this may not appear because we may have had an overlap contact, especially being that there's a cast restoration next door, or it might be tough to open that contact. In this imaging phenomenon with this camera, we're able to actually see this and get a three-dimensional perspective. You're able to see the lesion and get a buccolingual standpoint as to how large the lesion may be. So it's giving us something beyond our traditional eyesight. This is another device. This is called Spectra by Air Techniques. It operates on a principle of fluorescence. Essentially, strep mutans gives off a byproduct called a porphyrin. When a certain wavelength of light hits this porphyrin, porphyrins fluoresce. The presence of this porphyrin has been closely linked to caries, and when Spectra is used, it basically gives you kind of a Doppler radar type approach, where it maps the tooth and gives you indications as to where a healthy tooth structure is and where tooth structure is that may be of concern. In the three images you see here, we see the initial tooth, the tooth under the Spectra image, and then the tooth section and histologically stained. And as you can see towards the right, and in the middle photo there, towards the right hand or distal pit, there's a large fluorescent orange area that represents the caries that we see that's progressing well beyond the DHA, approaching the pulp. So this technology is, again, not replacing our brains, rather it's giving us another objective medium to assess the dentition. Now, we've all become accustomed to looking at caries. However, how about the teeth that are pictured here in this slide? These are all images from Dr. Lucy's book titled Dental Erosion from Diagnosis to Therapy. And I think it's a great read for anyone that's interested in the field of dental erosion. All these images here on your screen are various types of erosion. There's not a single image where caries is present, and none of these images none of these issues are attributed to parafunctional habits or bruxing type wear. Rather, these are erosive lesions that are occurring. These individuals are not bruxers by any means, and an occlusal splint will not stop the destruction in their mouth. Unfortunately, many times we see occlusal wear on posterior teeth, and the determination is that the patient may be a bruxer. Quite frankly, that may not be true in many instances. Those services may not even be contacting. Rather, they may be acidic issues that are at hand. So what causes tooth wear? We know from a caries standpoint it's really a bacterial approach. But from a tooth wear standpoint, how does it occur? Well, tooth wear occurs for multiple reasons, as we know, and we must help diagnose why an individual's enamel is going away. Is it due to a toothbrush? Is it toothpaste? Is it beverages such as these Red Bulls and Monster beverages? Are these sodas that are out there? Are patients bruxing? Are they grinding in parafunctional movements? Are they holding things in their mouth? These are all potential causes of tooth wear. And as practitioners, we must help kind of get to the bottom of why that's occurring. Now, here are some of the primary areas of tooth wear that occur. We have physical loss of tooth structure, and physical loss of tooth structure occurs via abrasion, attrition, or abfractions. And abfractions are somewhat debatable as to whether they occur. So from an abrasive aspect, we can see that occurring and we can also see attrition occurring in a patient's mouth. But the other side of what can cause tooth wear is chemical loss. And chemical loss in many ways leads to an erosion. So when there's chemical loss that's occurring, so we're losing dentition, enamel, and dentin because of acid erosion type phenomena, that's chemicals that are causing that tooth structure to be lost. But in many cases, the loss of tooth structure is actually multifactorial. It's not simply abrasion or attrition or erosion. It can actually be a combination of all the above. So these are all factors that we need to take into account. While all causes of tooth wear are destructive, the cause of tooth wear that we're going to focus on for a bit of the presentation here is really that erosive aspect and how we can help diagnose it, and equally important is once we diagnose it, how we can help prevent it from getting worse and manage the erosive process. So erosion is a physical result of a pathologic, chronic, localized loss of hard dental tissue that's chemically etched away from the tooth surface by acid and or chelation without bacterial involvement. So in the image that you see here on the right-hand portion of your screen, these teeth are not in contact with the opposing dentition. This patient actually has edge-to-edge, cuspal edge-to-edge occlusion. The palatal cusp and lingual fossas that were present here were actually out of occlusion with the opposing dentition. The patient is caries-free, yet there's been significant loss of tooth structure over time. The significant loss of tooth structure is occurring with some kind of an acidic attack. That acidic attack can be either extrinsic acids, meaning things that we drink or consume, or intrinsic acids, acids that are coming up from our own bodies. That's happening. When we think of dentin and enamel, we must think of what is the critical pH where demineralization occurs. Well, study will show that enamel demineralizes somewhere between 5.2 and 5.5, pH of 5.2, 5.5, and that dentin demineralizes around a pH of 6.7. Now, in the world around us, many of the drinks that we have actually have a pH below these numbers. So there's an acidic attack occurring every time we consume certain fruits and vegetables or every time we consume certain beverages. Now, the key is, are we able to buffer those acids that come into the mouth? So here's a patient that recently presented to my office. He came in with a chief complaint that he is not chewing well as he once did. He also stated that he has never had a cavity in his life. If we look at his occlusion, you can see that he is edge to edge. The incisal edges of the two upper central incisors come into contact with the incisal edges of the lower incisors. If we look at the posterior portion of the dentition, essentially there's, again, cuspal contact or incisal edge contact that's occurring. The patient has a bit of a crossbite that's present. Right? So palatal cusp in this patient's case of the maculated teeth are not in contact really with anything. If you look really closely at the upper right-hand image, you'll see the tremendous destructive erosive pattern that's occurred, and the palatal cusp of the bicuspids are completely missing. And the lingual fossa of the anterior teeth are missing, has worn away. And as we move posteriorly, we continue to see some wear and some pitting. If you look at the mandibular arch, you see the second molars. The dentin is showing through. There's some evidence of that in the first molars. And the lower anterior teeth are the ones that are actually being protected here. In this patient's case, he was actually prescribed a night guard, and not by our office, but by the prior clinicians he had seen. And they said to him, you're grinding your teeth, and that's why you're getting all this wear. If you look closely at those canines are essentially untouched. The form of those canines are pretty close to the form as well when they first came into his mouth. If this patient was grinding in lateral motion over many years, we would expect to see wear occurring. So we have to be very, very careful in our diagnosis, and that we simply don't put occlusal splints into patients' mouths when we see wear. One of the concerns becomes is that this patient has an acidic component occurring, and that the acidic component happens to be an intrinsic acid, so gastric reflux and or bulimia. If it's reflux in particular, and we put an occlusal splint in this patient's mouth, and we can actually, in fact, get acid coming up from the esophagus, going into the occlusal splint and getting in between the tooth structure and the splint, in actuality exacerbating or furthering the erosive process. So it's a major concern. So patients like this, we want to manage. We want to be able to put something in their mouth via a chemical standpoint to help buffer the acid. And we'll talk about some options that are available to us in the marketplace, thankfully. When we think about erosive lesions, we have to look for, what are the signs that are out there to tell us that there may be erosive lesions in a patient. So some things you want to look at is for our broad concavities with smooth surface enamel. We might see cupping of occlusal surfaces and incisal grooving. Really wear on non-occluding surfaces. So when teeth are not in contact with each other, yet we get wear, generally speaking, that's some kind of an erosive aspect, intrinsic or extrinsic. At times we have raised restorations. And what I mean by raised restorations is we've all seen patients come into our practice where they have what we call it a high and dry amalgam, where the alloy hasn't worn away or the amalgam hasn't worn away, but all the enamel around that amalgam has, and that amalgam is now an island on the tooth. Those cases, generally speaking, are acidic or acid erosion cases. When we think of acid erosion, we must first look at intrinsic acids. So acids coming up from our gastric system. Okay? When we see patients with intrinsic acid issues that ultimately lead to wear, we have to think about, well, how do we diagnose these patients? And how do we determine if a patient may have bulimia, if a patient may have gastric reflux, or if there's something else entirely? On the left-hand portion of the screen, this patient was a patient that was diagnosed with bulimia. And the reason we know that from a dental standpoint, she mentioned it to us that she was a bulimic and had gone through therapy before restored her. But from a dental standpoint, what we can see is significant amount of erosive wear on the palatal surfaces, right, or lingual surfaces of the upper anterior teeth, with minimal to no wear in the posterior, right, less and less. The reason we get this is generally a forward head posture position. Okay. Now, how do we know bulimia or GERD again? So on the right-hand side of the screen, this patient's a little bit different. We see a different wear pattern here, which we're going to discuss in some more detail. Or is it something else entirely? Is that acid from somewhere else entirely? So GERD, or gastric esophageal reflux disease, is a really big issue around the world today. There's a significant issue, and many of us see patients in our practices every day that most probably have GERD and are undiagnosed. These are undiagnosed patients. And dentists and oral health care providers can be some of the first to actually help diagnose patients with gastric esophageal reflux. So prevalence of GERD is thought to affect 45 million people in the United States. There's 54 million prescriptions written per year for Prilosec, and Prilosec now is even over-the-counter. That does not include all the over-the-counter prescriptions that are also written. About 5% of our children have reflux, and as obesity rates increase, chances are the incidence of GERD will also increase. When we think about gastric reflux, there's a few key signs that are out there. One is going to be the lingual wear of the maxillary anterior teeth. Okay, so this can be similar to bulimic patients in many ways, but we tend to get lingual wear of maxillary anteriors. We also get palatal wear of the maxillary posteriors, occlusal wear of the maxillary posteriors as well. However, in addition to occlusal wear of the maxillary posteriors, the buccal cusps of the maxillary teeth are generally intact. So if you have a patient with palatal cusps are worn, occlusal tables are worn through acidic erosion, and the buccal cusps are not, that's generally one of the key indicators. In addition, the mandibular posterior teeth tend to have occlusal wear and many times buccal cusp wear as well, because the acid comes up from the mouth, it hits the palatal cusp and then spills down onto the occlusal tables of the lower teeth and over the buccal cusp. The lower front teeth tend not to be impacted because that's where the tongue tends to protect those teeth and covers them, as well as salivary glands are allowing a more basic environment to form. So it's very common also to see unilateral wear. So a patient that tends to experience reflux at night when they're sleeping, most likely may sleep on the right side and or left side. So if you see more wear on one side versus the other, these are generally patients that may have gastric esophageal reflux. So we take a look at that photo again that I showed to you a few slides ago. We can see this patient has the lingual surface of maxillary anteriors as well as palatal cusp wear of the posteriors. At one point, a prior clinician had done a single crown on an upper second molar. You can see that tooth is protected, but everything else in the maxillary dentition is showing signs of acid reflux that are present. Now, patients that have significant acid reflux where they're aware of it may have that forward head posture as well, because they're actually at times bringing up vomit into their mouth, and it becomes an active process as well. And now acids clearly are not only intrinsic, they're also extrinsic. And extrinsic acids can do a significant amount of damage. This can be things like white wine, energy beverages, fruits that are out there. These are all things that can cause damage. Here's a patient that presented to the university with extensive erosion. He reported that his teeth are getting sensitive and that his mouth has deteriorated over the last year. After having the patient keep a food log, we had them keep a food log over a period of time, we discovered that he was drinking 6 16-ounce bottles of lemon iced tea Snapple every day for the last year. The reason he did this is he wanted to be healthier. He used to have a diet high in soda and coffee, and he wanted to move to a healthy alternative, so he moved to Snapple. He felt it was more of a juice versus a soda. And when he did that at 6 16-ounce bottles a day, you can see that the tremendous amount of erosion we started to see on the facial aspect of the bicuspids in particular, right? And essentially any tooth that wasn't restored in the past was starting to show significant signs of erosion. And this was all due to what he thought was something healthier in Snapple. Soft drinks get a bad rap for causing significant amounts of destruction. Unfortunately, there's other drinks that do a bad job as well. Now, we can't forget soft drinks, though. In many parts of the world, we're drinking more and more soft drinks today. And while there's other erosive things that are worse, many of our children enjoy drinking soft drinks, as do adults. So erosion doesn't just happen on someone who may be in 40s, 50s, 60s, etc. Significant erosion happened on a 13-year-old. Here's a case study that came out of a journal of Swiss Dental Association. And what you can see here is palatal wear or lingual wear of the upper incisors. And if you look really closely, there's a healthy enamel rim on the cervical aspect right at the tissue level. This patient was drinking a tremendous amount of soda every day. That soda was, the way it was being consumed is it was almost sipped through the front teeth so that it was hitting the lingual surfaces of the maxillary central incisors and lateral incisors. So it was the manner in which the soda was being consumed. It wasn't being gulped and put into the back of the mouth. It was coming through the lingual aspect of the upper teeth. The reason we see that enamel rim that's intact on the cervical third is because in this patient's mouth, with that acidic contact that's occurring, one of the most basic aspects is actually where some plaque is sitting. So some plaque is sitting at the cervical margin. It's relatively less acidic compared to the soda that's being consumed. And that's almost acting as a buffering component to protect that enamel. And many of us see this very commonly in our practices where we see the fossa eroded, but we don't see that happening in the cervical third. Now, acids can come from things beyond drinks. Now, here's Michael Phelps. We all know him, and I'm not here to say that Michael Phelps has any kind of erosion. I don't know him personally. But swimming pools can actually cause erosive aspects. So we have patients who are swimmers, water polo players, etc. In our practice, we had a water polo player that was showing significant signs of erosion. And these things can actually be tied to the pH level within a pool. So here's an image coming from a case study out of Canada. So this came from the Journal of the Canadian Dental Association, published in May of 2008. And what you can see here is a composite was placed on an upper right central incisor, so maxillary upper right central incisor. This composite was placed, this resin was placed 2 weeks prior to the patient taking a trip to Cuba. She reported that on her trip to Cuba, she spent 2.5 hours a day in the pool for 2 weeks consecutively. And when she came back, the only remnants of where the original tooth form was of the central incisors and lateral incisors was that composite that the clinician had placed. Now, I'm fairly confident the clinician that placed this composite 2 weeks prior did not artificially raise the facial structure. This was most likely in alignment with the adjacent enamel that was present. But in a 2-week standpoint, significant erosive wear occurred through intake of the water, and it's estimated that the pH of the pool was below 3. The patient reported that she had a funny taste in her mouth. You would think it would burn her eyes, but she wore she had worn goggles the entire time and didn't realize the amount of destruction that was occurring. Posteriorly, you can see these are starting to become more high and dry alloys that are present in amalgams. Now, if we look at caries and we look at erosion, we have to look at these things and think, well, what can we do to help protect ourselves? These are significant risk factors, and there's disease indicators that are present. If we need to protect the oral environment and help protect our patients, we need to stack the deck in their favor. And if we think about this scale, we have to add multiple protective factors. Proper oral hygiene at home and dietary control are two things that can be done from a patient's perspective, But as clinicians, we must think, what else can be done to help change the oral environment? Well, there's multiple products in the marketplace today that can help change this oral environment. Some can attack caries, others can attack caries and be preventive mechanisms for those who have erosive diets, right? And some can be both. So we have to really look at the marketplace and see what's out there. We know when patients have erosion issues, their teeth tend to get sensitive. So there are ways to protect teeth, potentially do some types of varnishes that actually help seal tubules as well and help from a protective aspect. So we need to look at a host of therapies that attack different areas and really of salivary makeup. We must fight caries as well as maintain a more basic environment in the mouth to help buffer the intrinsic and extrinsic acids that our patients face. So we take chlorhexidine and gluconate. Well, chlorhexidine and gluconate tends to show mixed results in terms of research in caries management. If we follow a 1 week on, 3 week off regimen, so a patient uses the chlorhexidine for a week, then for 3 weeks they're off it, they switch for about 10 milliliters for 1 minute a day, roughly at bedtime. What we tend to see is a decrease in mutant streptococci levels. Those tend to decrease. Now, does that suddenly lead to a completely healthy environment in terms of caries? The literature is mixed, but we know there's some benefit. Okay? If we go this 1 week on, 3 weeks off regimen, we tend not to get stain. There's a definite periodontal benefit here, but the benefit to caries may be marginal. Now, if patients who have sensitivity, especially due to erosive aspects, if patients are complaining about sensitivity, we can consider applying fluoride varnishes. And there's varnishes that are specifically developed, in this case, here's Profluoride L by Voco, that are specifically developed to help fight hypersensitivity. And these varnishes do not impact whitening procedures in any ways. They don't interfere with it. So these varnishes are very interesting. And what they do is they go beyond just fluoride therapy. They take into consideration sodium, fluoride, and calcium. Okay? So Profluoride L by Voco combines these three components, sodium, calcium, and fluoride. And they offer short-term and long-term protection. It's really important to have calcium source. Fluoride is a great additive to have. It helps put down fluoroapatite, and fluoroapatite does a great job of helping to prevent caries and actually helps fight acidic challenges. But calcium actually helps rebuild natural tooth structure. So calcium becomes an important additive, and we want to really look at that in conjunction with fluoride. It's not a one or the other phenomenon, but rather both together. And certain products really help combine both. Some of the indications of this product would be, we use it in our practice after scaling and root planing to decrease cervical hypersensitivity. You can also use it in areas of cementum that have been exposed due to recession. From prosthetic standpoint, maybe around crown margins. You might be using it after bleaching when a patient's sensitive. So these factors that are here that lead to both short-term sensitivity decrease as well as long-term. So in the short term, there's some fluoride components that are really beneficial in the sodium fluoride. But in the long term, that calcium benefit can really help out. Now, in addition to kind of sensitivity varnishes, there's true fluoride varnishes. And fluoride varnishes tend to work very well and is accepted more readily by patients versus traditional foam trays. We haven't used foam trays in our practice, for 7 or 8 years now at least. A product like Voco's varnish here adheres to tooth surface very well and allows for a much longer contact time compared to foam alternatives. In our practice, we also regularly use varnishes on adult patients that show a moderate to high caries risk as well as erosive lesions or issues. We don't believe varnishes are simply for children. They can absolutely be used on adults. Now, fluoride, through numerous studies, fluoride has proven to be an agent that helps prevent caries and change tooth structure that has been damaged to more acid-resistant fluoroapatite. Traditional enamel demineralization, as we discussed, occurs at around a pH of 5.2 to 5.5, and dentin demineralization occurs at a pH of 6.7. On the contrary, fluoroapatite can take a much more significant acid challenge and does not demineralize until a pH reaches 4.5 in the oral cavity. To this end, Riemann Pro and things like Voco's fluoride varnish really help out. So these products, the fluoride varnish has 22,600 parts per million fluoride. That really helps to give an in-office regimen to help fight erosive and caries lesions. And there's also an out-of-office regimen we'll discuss shortly. There's also products like xylitol. Well, xylitol is a natural sweetener that tends to be more forgiving to the dentition compared to sugars such as sucrose. But over the years, the literature has been mixed as to whether xylitol can also aid in remineralization of enamel and dentin. And the literature has shown that approximately 6 grams of xylitol per day must be consumed to really show remineralization benefits. Regardless of the efficacy of remineralization, the clear benefit of xylitol is that it decreases the growth of bacteria such as strep mutans and possibly lactobacilli, and increases the production of saliva. Saliva is probably one of our best buffering components, and if we can increase the production of it, that's a great thing. This mechanism of with xylitol where it works really allows for less acid to be produced and creates a more favorable oral environment for sustained long-term health. One of the products I really like in the marketplace today is Remin Pro. We talked about fluoride and xylitol, and we talked about calcium components. And Remin Pro really combines all those aspects. When I think of achieving a caries balance, I want to look at combination therapy. This product, by combining xylitol, fluoride, and hydroxyapatite in one simple paste, gives something that's easier for patients to use. It's an efficient use for our patients. And we have to be realistic and say, if we throw 4, 5, 6 products at a patient, are we really giving them a chemistry set in order to be able to help work on their issues that they're facing? Or can we look at more simplistic products? So these are highly engineered products combining xylitol, hydroxyapatite, and fluoride that are combined into an easy-to-use paste for the patient. And we'll talk about how we use that paste. So the 3 key ingredients, to kind of reiterate here, are 1,450 parts per million fluoride. There's also hydroxyapatite components, there's nanohydroxyapatite. That's really calcium and phosphate ions mixed together, which helps build kind of natural tooth substance. And then there's xylitol. And all those 3 things are in one combined product. The combination of these products supports remineralization, helps strengthen teeth, leads to smooth tooth surface, neutralizes acids, and also desensitizes. So we have a multifactorial component that a single product is able to do. Now, hydroxyapatite itself is very interesting, and nanohydroxyapatite in particular. Nanohydroxyapatite can be thought of as kind of the special sauce in Remin Pro. The beauty of this product is that it has a very small molecule size. And this small molecule size gives it the ability to penetrate deeper into demineralized enamel and dentin. This molecule has the ability to fill enamel irregularities, as well as provide a surface filling to dentin or exposed root structure. The resulting smooth surface makes adhesion of dental plaque much more difficult. And the secondary benefit is that the visual increase of tooth gloss becomes apparent. In addition, in a recent in vitro study published in the Journal of Dental Research, one of the highest impact factor journals out there, biofilm, we all have biofilm, actually enhanced the nanohydroxyapatite ability to reduce demineralization effects. This is really fascinating. Penetrating biofilm can be very difficult to do, and at times it's hard to achieve. Nanohydroxyapatite actually works in the presence of biofilm, and the fact that it does this is very promising for the dental profession in our patients. Many studies today show that hydroxyapatite works well in the reduction of caries formation. It helps seal tooth surface, right? Helps repair incipient caries, and that delay of plaque formation. So multiple hydroxyapatite products are showing this. And hydroxyapatite is really a regenerative material. We're moving to a place in dentistry where we're simply not kind of filling in issues that have occurred, but rather rebuilding natural tooth structure, and hydroxyapatite helps to do that. Now, sodium fluoride is another product that is another aspect that's in many products today. And it's a proven agent to really help fight caries. On the tooth surface, fluoride is converted into more stable and more acid-resistant fluorapatite, as we talked about, right? And that 1,450 parts per million contain a Remin Pro really helps that tooth structure fight off acidic attacks. Xylitol can really beneficially affects oral plaque properties. Right? It makes plaque less cariogenic. And the way it does that is from a standpoint of transforming this dental plaque, really transforming things, and helping fight off acidic attacks that are recurring. Now, the only problem with xylitol is there needs to be a truly high effective dose when xylitol by itself is going to work. But in combination with other things, there's a clear benefit. So it's a combination of that fluoride, xylitol, and nano-hydroxyapatite. The way I like to apply Riemann Pro and PACE type methodologies is to really start to look at two things. We can apply it with a toothbrush. That might be easy to do, or with our finger. But a more effective way is really to think about tray therapy. So rather than making bleaching trays for our patients, we do that as well. We also make a caries reduction or desensitization trays. Essentially, that's the same process as making a bleaching tray. The only thing that we do differently is we trim it less aggressively. We have the tray go all the way down to the tissue. That way the tray can be filled. And really the minimum contact time for a product like Riemann Pro to work, the minimum contact time is about 3 minutes. What we ask our patients to do in high caries risk patients is I have my patients load the tray, and I have the patients wear that tray for about 10 minutes. And generally speaking, for high caries risk patients, I have them do this at least once a week, but more often than not, I'll have them do it 2 to 3 days in that week. So 10 minutes for 2 to 3 days. I say, after dinner, et cetera, before going to bed, let's go ahead and pop this in for about 10 minutes, and that should really help out 2 to 3 times a week. Now, the reality is we cannot treat all issues chemically. At times, we must treat surgically. And while we've talked about these preventive and risk-based protocols, the reality is that surgical treatment needs to occur at times. And we must remove disease in patients. We can't hope that every patient is going to find religion and change all these modalities in their mouth, right? The patients have to be very active in the process for chemical therapy to work. If they're not, we really have to go to a surgical-based approach, right? Or at times, the lesions may be too big to remineralize. We have to think about a surgical-based approach. So in a surgical-based approach, I think it's very, very important that we think about things to keep breast preparations as small as possible. I would highly recommend that we do whatever we can in our ability to keep preparations very small. We must be cognizant when we embark upon conservative dentistry that we have the right armamentarium, that we have the right burrs to help remove the disease process in the most conservative way possible. If we diagnose something early and then take a large burr in to remove that disease, we're taking away unnecessary amounts of tooth structure. Now, there's many ways to do conservative preparations that are out there today. Some may choose to use things like a laser. And I think if you're doing surgery in your practice, if you're doing periosurgery, something like a laser may be very beneficial to you. But a laser is high cost. And all of us in practice, and depending on where you are in the world, et cetera, can't suddenly invest $30,000, $40,000, $50,000 into a hard tissue laser. But something we can do is consider minimally invasive rotary instruments. And so in my practice, I don't do any surgery. So in my practice, a laser doesn't make a lot of sense for me. If I did periodontal surgery, I can see the value of it. But if I'm simply using a hard tissue laser for minimal preparation of enamel or a dentin, the ROI doesn't work for me. What does work is a conservative burr. The burrs I happen to use are burrs like this, the 1300S burr by Microcopy. Costs under $2. And it can take a very conservative amount of tooth structure away. SS Whites makes Fishrati burrs, etc. Conservative instruments that are out there. At times, you may consider things like air abrasion units. So there's air abrasion units out in the marketplace today that combine a water spray with aluminum oxide, so that combination doesn't create a big plume in your office, rather conservatively removes diseased tissue from teeth, right? In these micro prep burrs. So that's how I like to approach minimally invasive dentistry. So I diagnose on the front end, right, through caries detection technologies as well as clinical judgment, and I mix that with devices that are going to help me remove caries very conservatively. Now, I'm a big proponent that any resin dentistry we do today must be done under proper isolation. And the gold standard of isolation is really a rubber dam. And I would never argue that a rubber dam shouldn't be put on. I think a rubber dam is fantastic, and I use a rubber dam quite frequently in my own office. At the same time, I also realize that a rubber dam can be cumbersome to put on. But there's devices that are out there today that help create a very dry field that takes away the moisture contamination and creates a very dry field that's also retracted. And products like Icelite or Zurich's Mr. Thirsty or the new Dry Shield that are out there, they all do a good job. And whichever one you pick and or a rubber dam for you, I have no qualms, so they all work really well. But in addition to keeping the area dry, we also need to look at things like microbrushes and condensers. If we're not using solely a flowable composite or a really thin adhesive, we might even want to consider things like American Eagle's instruments here that are very small micro prep instruments, right? If we don't use these small instruments, things like small microbrushes, the concern becomes is once we acid etch tooth structure, the dentin, the smear layer is removed, there's going to be some potential sensitivity because in a micro prep or small preparation, adhesive may not get all the way down to the pulpal floor. And when that doesn't occur, fluid can be exchanged between the dental tubules and the gap that's formed, causing sensitivity. Those are those fillings that we do that are far away from the pulp, and patients report sensitivity upon biting. So we have to think of small instruments that go in there. And one of the things I really like is this little microbrush, this Endo Micro Applicator by Voco. It's a very fine-tipped applicator or a super fine microbrush that's out there as well. And once I acid etch tooth structure in dentin, enamel and dentin, I can take this fine microbrush in, go ahead and apply my adhesive properly, and then cure it, air thin it, and then cure it. A typical example of very conservative class 1 type restoration is a patient like this. So in this patient's case, they presented with mesial caries on the upper first bicuspid. When I first looked at the tooth, like many of us, we said, well, is that stain or is that caries? Went ahead and did a kind of an ICDOS evaluation of it, so looked at it both wet and dry, determined that somewhere between a 2 and a 3. I went ahead and utilized one of my caries diagnostic instruments. The caries diagnostic instrument said, okay, most likely caries are at the DEJ level. So we decided to do a PRR, or preventive resident restoration, where we conservatively removed the disease process that was present, right? We took that away, did a micro preparation with a microburr, used an isolation device, in this case, etched the tooth, applied adhesive, and then simply filled the restoration with flowable composite. The only material that is used here is flowable composite. There was a time where flowable composites didn't work really well. Thankfully, we've moved past that today. In years past, flowable composites were really kind of the duct tape of dentistry. They were meant to fix provisionals, act as liners, and really not do a whole lot else. Today, flowable composites have truly improved, and they're highly engineered restorative materials. Flowable composites are true restorative materials today, and I use them quite frequently in my practice. It's important to realize, though, that all flowables are not created equal, and that flowables have different properties that are at hand. Good news is there's very good flowable composites in the marketplace today that have different flow characteristics. Some may stack, and some may have more viscosity, and others may have less viscosity. Some flow more, and some stack more. There's different aesthetic options that are out there today and how they look, different delivery options that may be out there, and there's very good physical properties of materials that I'm going through here. And then some of them are just very strong. So there's a whole host of flowable composites today in the market, and they're essentially product specific. So in my practice, I don't simply have one flowable composite. Rather, I think of flowables as a restorative material that you need to use the right material at the right time. If I'm doing a conservative class 1 occlusal composite, or maybe a conservative class 3, or maybe even a conservative class 2 restoration, the conservative class 1s in particular, what I really like to use is Voco's Grandioso Heavy Flow Composite. I think it works incredibly well. And the reason it works so well is because I can predictably put it into function. These are not wide preparations where I'm really concerned about shrinkage issues. Generally speaking, flowable composites do shrink more than traditional composites, but shrinkage is really dependent upon the volume of material that's put in place. In a conservative class 1 lesion, I'm putting a small volume of material. So even though the volume of material may have a higher shrinkage, I'm not so concerned about it. When we look at flowables today, there are flowables that are very, very highly filled. So Voco's Grandioso Heavy Flow is 80% filled. It's a highly filled flowable composite. And I've been using this material for 4 or 5 years now, and I have no concern about putting that material in function on a patient. And the reason I don't have a concern is that this material in particular has comparable compressive strains to traditional composites. That doesn't mean you should go in and cut a wide preparation that's 4 or 5 millimeters in width and then fill that entire area with a flowable composite. But what it does mean is in the right dimensions, with conserved restorations, we can have very predictable compressive straight phenomena. And if we compare things to great composites like Filtek Supreme XT or Color or Tetrag, these are all very good composites. Voco's Grandioso Heavy Flow has a very similar compressive strength. That's there. Now let's look at more traditional restorations. In this slide that you see here, here's a lesion that on the bite ring radiograph, I noticed that there may be a carious lesion starting on the mesioproximal surface of the upper left first molar. I went ahead and used my CariView instrument, which was a high-intensity light that was shot into the tooth. And what I can see on that, with that instrumentation is that we in fact had a mesioproximal lesion that was not only an enamel, but that was extending right to the DEJ. Here's a clinical view of the tooth that was present. So in this case, we decided to do a conservative class 2 restoration, went ahead and isolated with a rubber dam, put a protection matrix in. Nearly 60% of all adjacent teeth are hit on class 2 preparations. So as clinicians, the first thing we want to do is no harm to adjacent teeth. So I went ahead and put this protection matrix in. We pulled it out slightly for the photo to show you the class 2 lesion that's present. Went ahead and used a selective etching technique and then used a universal bonding agent. There's many great universal bonding agents that are out there today. And then we used a bulk fill flowable composite. We had a depth of approximately 4.5 millimeters in gingival depth there, pulpal depth that was present. So we said we're going to use a single increment or 2 increment bulk fill depending on your technique. We used a bulk fill flowable composite in this case and put a capping composite on top of that to combine the two together for a nice end result with a nice class 2 restoration restored. Now in terms of bulk fill composites, there are many excellent bulk fill composites today. So really it's a matter of which bulk fill flowable do you want to use. There's a few that are out there. There's some that are true bulk fill flowables. So these are materials you put down and you put a capping layer on top. And that's the case with Venus Bulk Fill Extra Base, Beauty Fill Bulk, and then SureFlow SDR Flow. And there's materials like Sonic Fill that combine some of the aspects of both worlds. They have a high viscosity that then drops to a different viscosity material. And those go in as a flowable but then stiffen in that standpoint. So the concept here is there's no longer a one-size-fits-all modality. You as a practitioner get to choose. And the really good news today is that studies are showing that bulk fill composites quite frankly work. So the ADA did a beautiful study back in 2013. They looked at a whole host of the major bulk fills in the marketplace. And some of the bulk fills they looked at were Tetrag EvoStrand Bulk Fill, Extra Fill by Voco, and then Sonic Fill by Kerr. And each and every one of these materials were shown to be acceptable according to the international standards. They all worked. And I in my practice use bulk fills regularly. And over the last 3 to 4 years, or maybe almost 5 years I've used bulk fill composites today, quite frankly, I've had no issues. Whether that's using Extra Fill Base by Voco first and putting that down, then capping with something on top, or using Sonic Fill by Kerr, these all work very well, as long as they're used according to the manufacturer standards. The manufacturers give you a clear indication of what the thickness should be when you place it, what intensity of light should be used. And if we hold to those parameters and don't push beyond those parameters, these materials work very, very well. Now, in roughly the last hour that we've had together today, we've covered a number of topics, right? But I think there's a few take-home points. And the take-home points today are really dentistry's come a long way. And dentistry today, we have to think about really, what is the etiology that's causing issues? Is it caries? Is it erosion? What is it? What's causing the destruction that's occurring on enamel and dentin? By determining that destruction and determining the extent of destruction, we have to then say, what can we do to make it better? Can chemical treatment make this better? Can surgical treatment make this better? Or is it a combination of both aspects? If we need to enter surgical treatment, I think it's incredibly important to really think about a micro-invasive approach. Take away as little tooth structure as possible in order to get the proper end result we're looking for, right? And then we want to use the right restorative material. There's phenomenal flowable composites that are out there today. There's great universal adhesives that are out there today. There's very good bulk fill materials out there today, let alone traditional techniques. So these are all things that we have options for in dentistry today that we didn't have options for in the past. So we really need to take all those things into account.